Hello everyone. Today we will be diving into a cornerstone of clinical nutrition and patient care. The intricate relationship between water, electrolyte and acid-base balance. Over the next minutes, I will explore how these three elements work in the concert to maintain the body's internal environment, a state we call homeostasis. Understanding these principles is absolutely critical for managing patients in any clinical settings, as imbalances can lead to severe and sometimes life-threatening complications. So let's begin by establishing why this concept of homeostasis is so fundamental to clinical practice. So in this lecture we will talk about the four sections. The first one about body water, electrolyte, acid-base balance, and the final section we will summarize this lecture. So we will start with body water. So as the slides says, the balance of a fluid, electrolyte base, the level is critical for optimal cell function. So think of it as body's internal operating system. When it's balanced, everything's runs smoothly. However, disruption are incredibly common in hospitalized patients due to illness, due to trauma, due maybe or even certain medical treatments. So throughout this presentation, during this lecture, we will first cover the essential rules of water in the body. Then we will examine the specific functions of key electrolyte like sodium, like potassium and calcium also. Finally, we will unravel the principles of acid-base balance and how the body regulates its pH. So, to truly understand the fluid balance, we have to start with its largest and most important component. It is water. So, water is by mass the most abundant molecule in the human body. As you can see, the percentage of body weight that is water changed significantly through the lifespan and varies with the body composition. For infants, for example, in infants, body is about 75 to 85% water, which is why they are so vulnerable to dehydration, this infant. In adult, there is a key difference between lean and obese individual. Depends on present muscles, how the quantity of muscles in this body, or how fat percentage in this body. So lean adults consist from 60 to 70% water, whereas an obese adult of the same weight might only 45 to 55% of water. This is a crucial point to remember when calculating fluid need for patients. Now that they appreciate how much of our body is made of water, let's explore the vital functions it performs. Functions of water. Water is far more than just a space filler. It's an active participation in nearly every physiological process. It's the universal solvent, making solutes like glucose and electrolytes available for cellular reaction. It regulates the body temperature primarily through sweating. It's the main component of blood, maintaining blood volume and also transporting nutrient to our cells and waste products away from them. It is also essential for digestion, absorption and excretion. It is important to note how sensitive our bodies are to change in hydration. Even a mild 1 to 2% loss of body water, something an athlete might experience during a workout, can lead to measurable declines in cognitive function, alertness and physical performance also. So these diverse functions are carried out by water that is disrupted across different compartments within the body. So let's take a look at where this water is located. The total body water is broadly divided into two main compartments. About 2/3 it is intracellular fluid, ICF. It's located inside our cells. So intracellular, inside our cells. The remaining 1/3, about 1/3, which is all the water outside the cells, and called ECF. ECF is further broken down into plasma. What is plasma? Plasma is the fluid component of blood, also lymph and interstitial fluids, which is the fluid that directly bathes our tissues and cells. So there is also concept known as third space fluid. This fluid that accumulates in parts of the body where it is not easily changed with the ECF, the extracellular fluid, such as in the abdominal cavity in a condition called ascites. This third space fluid is essential, trapped and non-functional, so patient can have significant edema or ascites and still be effectively dehydrated from a circulatory standpoint. So a very common clinical example of the third spacing fluid is edema, a condition that warrants a closer examination. So edema is the visible and palpable swelling caused by this abnormal accumulation of fluid in interstitial space. It is four primary causes. The first one, a decrease in cortic pressure, which is a pulling force that proteins like albumin exert to keep fluid inside blood vessels. In conditions like severe liver disease or malnutrition, in low protein level cause fluid to leak out into the tissue. The second, increase capillary permeability, where inflammation for trauma or burns makes capillaries leaky, allowing both protein and fluid to escape. The third one, increased hydrostatic pressure, which is pushing force of the blood against capillary walls. In heart or kidney failure, this pressure can become so high that it forces the fluid into the interstitial space. And finally, number 4, lymphatic dysfunction, where the lymphatic system, which normally drains excess fluid, is obstructed. So the movement of fluid that leads to conditions like edema or is governed by a delicate balance of these physical forces, which we will discuss in next slides. So, to recap, hydrostatic pressure is the force that pushes fluid out of the capillaries. So osmotic pressure, this is the hydrostatic pressure. So hydrostatic pressure pushes the fluid out of the capillaries, while osmotic pressure pulls the fluid across membrane influenced by solute concentration. A specific type of this is oncotic pressure, which is the osmotic pull generated by large molecule like protein. At the cellular level, the sodium-potassium pump, sodium-potassium ET-base pump, is a critical player. It's an active transport system that constantly pumps sodium out of the cell and potassium into them. By controlling the location of these K electrolyte, the pump effectively controls the osmotic gradient and therefore where water goes. So this intricate balance is maintained by carefully regulating our water intake. So, what is the source of water? We get water from 3 main sources: the beverages we drink, the food we eat. Solid foods can contribute a surprising amount, around 19% of our daily total, and a small amount of metabolic water, which is produced internally as byproduct of metabolizing fats, carbohydrates, and protein. So water intake is primarily driven by thirst. What the definition of thirst? Thirst regulated by the hypothalamus, but sensitivity can be decreased in the elderly, infants, and athletes. So the thirst mechanisms become less sensitive in older adults, and it often can't keep up with the rapid losses seen in infants or heavily exercising athletes. Of course, intake must always be balanced by output. So let's now examine the route, the ways through which the body eliminates water. So water loss can be categorized as either sensible, meaning it's measurable, or insensible. The primary route of sensible loss is a urine, with the kidney acting as a master regulator or master regulators of a fluid balance. And feces also account for a small amount of sensible loss, though this can become very significant in cases of diarrhea. And on the other hand, insensible losses are those we are not typically aware of and cannot easily measure, so not measurable. This include water lost through expired air with every breath we take, and water vapor lost through the skin. These insensible losses are magnified by factors like high altitude, low humidity, and high temperature. When this balance of intake and output is disrupted and losses exceed intake, the result is dehydration. So dehydration, what are the signs and symptoms of dehydration? Dehydration presents with a range of signs and symptoms that reflect the body's attempt to compensate for low fluid volume. So neurological signs like headache and fatigue appear early. Poor skin, turgor, where pinched skin return the place slowly, is a classic sign, though it can be less reliable in the elderly. The kidneys will try to conserve water, leading to concentrated dark urine and decrease urine output. As dehydration worsens, you may see sunken eyes and dry mucous membranes. The cardiovascular system also responds with tachycardia, rapid heart rate, as the heart beats faster to compensate for a low blood volume, and orthostatic blood pressure change, where blood pressure drop upon standing. Because these signs can be varied and sometimes subtle, through clinical assessment is crucial to accurately determine a patient's fluid status. So what is the clinical assessment of a fluid status? It is important to understand that there is no single blood test or measurements that serve as a gold standard for hydration status. Instead, we must be detectives and synthesize information from multiple sources. The first source, physical examination, is a key looking for signs of edema or dehydration. Imaging reports like chest X-ray might reveal fluid in the lung. Laboratory studies, particularly serum sodium and kidney function test, provides important clues. We must also listen to the patient's reported symptoms like thirst or dizziness, and critically we must track sudden weight changes, as rapid changes almost always reflect fluid shifts, not the changes in the body mass, and review all fluids inputs and outputs. So fluid balance is inextricably linked to the concentration of electrolytes dissolved within that fluid. So let's now turn our attention to the topic of electrolyte. So electrolytes are minerals that carry an electric charge when dissolved in water. They are absolutely vital for a host of metabolic and physiological function, including nerve impulses, muscle contraction, and maintaining osmotic balance. A key concept is their distribution. Certain electrolytes are found primarily in extracellular fluid, the main ones being sodium, calcium, and electrolyte and chloride. So the extracellular, the main is sodium, then calcium, chloride, and also bicarbonate. Others are concentrated inside the cell, called intracellular, with potassium, magnesium, and phosphate being the major players. This separation is actively maintained and is critical for normal cell function. We will start our details exploration with one of the most well-known electrolyte, calcium. Calcium, while we often associate calcium with bones and teeth, where 99% of it is stored, the remaining 1% circulating in our blood is physiologically vital. It's essential for blood clotting, nerve signal, also signal transmission that I mean, and muscle contraction. Its level are very tightly regulated by complex interplay of the parathyroid hormone PTH and vitamin D. A very important clinical point concerns albumin. About half of the calcium in our blood is bound to this protein. Therefore, in a patient with low albumin, their total calcium level may appear vastly low. We must always calculate the corrected calcium to estimate the true physiological active calcium level in these cases. So next we will move on to discuss the primary cation of the extracellular fluid, sodium. But before go to next slide, hypoalbuminemia means low albumin levels can falsely lower total calcium. So that I mentioned before, corrected calcium calculation is necessary. Sodium is the king of extracellular fluids. Its main job is to regulate the volume of the extracellular fluid and plasma. Because water follows salt, wherever sodium goes, water will follow. It is also crucial for nerve and muscle function. Hyponatremia. The definition hyponatremia means low sodium, while hypernatremia means high sodium. So hyponatremia, one of the most common electrolyte disorders in hospitalized patients, and can lead to seizures and coma. And it is very dangerous. Conversely, hypernatremia or high sodium, it is also dangerous and indicate a state of significant water deficit. It is critical to understand that you can't interpret patients' sodium level without also assessing their overall fluid status. Are they dehydrated, overhydrated, or normal? And while sodium rules of the extracellular space, its counterpart potassium is the king inside the cells. So potassium is the major intracellular fluid cation, and it is work in the partnership with sodium to maintain water balance and is a key determinant for the cell's membrane potential, which is absolutely critical for neuromuscular activity. This is especially true for the heart. Both hypokalemia and hyperkalemia, low potassium and high potassium, can have devastating consequences on cardiac function, leading to life-threatening arrhythmias, and any significant deviation in potassium level is medical emergency that must be addressed immediately. Another important intracellular cation which often works in the background but is just as vital is magnesium. Magnesium is the second most abundant intracellular cation and acts as cofactor, a helper molecule in over 300 enzymatic reactions in the body. It is play a role in everything from protein synthesis and energy metabolism to bone health and cardiovascular function. Hypomagnesemia means low magnesium or can cause symptoms like muscle weakness and tetany. Clinically, it is often seen in patients with malabsorption issues or alcoholism. It's also a key feature of feeding syndrome and can cause other electrolyte abnormalities like low potassium and low calcium to be resistant to treatment until the magnesium is replaced. Now let's move from the cation to the primary intracellular anion phosphorus. Phosphorus in the form of phosphate is absolutely central to life as we know it. Its most vital role is a component of adenosine. Adenosine triphosphate ATP, the universal energy currency of the cells. Every energy requiring process in the body is powered by the breaking of high energy phosphate bound in ATP. It's also a key component of our cell membrane and DNA, deoxyribonucleic acid, and it acts as important buffer to maintain acid-base balance. Hypophosphatemia or low phosphorus can be life-threatening because it impairs energy production at the cellular level, leading to cardiac and respiratory failure. As we just mentioned with magnesium, it is a hallmark features of refeeding syndrome. So the critical role of phosphorus, potassium, and magnesium bring us directly to a very important and often dangerous clinical condition known as refeeding syndrome. So refeeding syndrome is a serious and potentially fatal metabolic complication that can occur when we reintroduce nutrition to a patient who has been in a state of starvation or is severely malnourished. So during starvation, the body metabolism shifts when food is reintroduced, especially carbohydrates. There is a sudden surge of insulin. The insulin surge causes massive shift of electrolyte, primarily phosphorus, potassium, and magnesium, from the bloodstream into the cell to help metabolize the new fuel. This causes their serum level to plummet dangerously, leading to severe consequences like cardiac arrhythmias, respiratory failure, and seizure. So the key to managing this prevention, we must identify at-risk patient and reintroduce nutrition slowly and cautiously while closely monitoring their electrolyte. This brings us to the final piece of our puzzle beyond the fluid and electrolyte. The body must also maintain a precise acid-base balance to function. So, acid-base balance.